In 1943, a Danish biochemist stood before the Nobel Committee in Stockholm to accept the prize in physiology or medicine. His discovery had taken over a decade to isolate and confirm, but the molecule he identified would reshape how science understood blood, bone, and the quiet mechanics of staying alive. That molecule occurs naturally in every blade of grass on this continent, in every pasture, every unmowed field, every suburban lawn stretching from Virginia to Oregon. And right now, in Japan, a pharmaceutical corporation sells a refined version of that same molecule as a prescription drug at pharmaceutical markup, packaged in blister packs and dispensed through hospitals. The molecule is a form of vitamin K, and the fact that most Americans have never heard its full story is not an accident. It is the result of a 70-year sequence of industrial decisions, agricultural shifts, and regulatory blind spots that quietly removed one of the most important nutrients in the human diet, and then allowed it to be repackaged and sold back under a corporate label in countries that still acknowledged what it could do. The story begins in Copenhagen in 1929. Henrik Dam was not searching for a new vitamin. He was studying cholesterol metabolism in chickens, placing groups of chicks on carefully controlled fat-free diets and observing how their bodies handled the absence of dietary fat. What he observed instead was far more alarming. The chicks began to bleed, not from injury or illness. They hemorrhaged spontaneously beneath the skin, in their muscles, in their organs. Something essential was missing from their diet, and without it, their blood refused to clot. Dam spent the next 6 years narrowing down what that missing factor was. By 1935, he had isolated a fat-soluble compound that restored normal coagulation. He named it coagulationsvitamin, using the Scandinavian spelling. The initial K stuck. Across the Atlantic, an American biochemist named Edward Doisy took the work further, determining the precise chemical structure. In 1943, both men received the Nobel Prize, Dam for the discovery, Doisy for the chemistry. It was one of the clearest Nobel Awards in the history of nutrition science. A molecule essential to life, found abundantly in nature, recognized at the highest level of human scientific achievement. But what the Nobel Committee honored in 1943 was only part of the picture. At that time, vitamin K was understood almost exclusively as a clotting factor. If your blood clotted normally, you had enough. End of conversation. That narrow clinical definition held for decades, and it is precisely that narrowness that allowed the rest of the story to slip from public awareness entirely. Vitamin K is not one molecule. It is a family of related compounds. Vitamin K1, called phylloquinone, is produced by every green plant on Earth during photosynthesis. It is abundant in dark, leafy vegetables, fresh herbs, and ordinary grass. K1 handles blood clotting, but there is another form that does something entirely different. Vitamin K2, known scientifically as menaquinone, activates a specific set of proteins that control where calcium travels inside the human body. Without adequate K2, calcium drifts. It deposits in artery walls. It accumulates in joints and soft tissue. It calcifies places it was never meant to reach, and it fails to arrive at the one destination where it is desperately needed, which is your skeleton. This is the part of the vitamin K story that was functionally invisible for the better part of a century. In the 1930s, around the same time Dam was working in Copenhagen, an American dentist named Weston Price was conducting field research across the globe. Price traveled from Swiss alpine villages to remote Pacific islands, studying the diets of traditional cultures that had not yet adopted modern processed foods. He found a striking and consistent pattern. The communities with the strongest teeth, the densest bones, and the lowest rates of chronic disease all consumed generous amounts of a particular kind of animal fat. It was richest in grass-fed butter. It was concentrated in the organ meats of pastured animals. Price could not identify it chemically, so he gave it a working name, Activator X. He documented its ability to reverse dental decay and promote skeletal integrity. He published his findings extensively. And then, for more than 60 years, his work was largely dismissed by mainstream nutrition science. It was not until the early 2000s that researchers confirmed what Price had been documenting all along. Activator X was vitamin K2, specifically the MK4 subtype, a form of methionine that concentrates in animal fat when ruminant livestock eat fresh green grass. The mechanism behind it is ancient and remarkably elegant. Grass produces K1 during photosynthesis. A grazing cow eats the grass. Bacteria in the cow's digestive system convert that K1 into K2. The K2 then accumulates in the animal's fat, its milk, its butter, its organ tissue. When a human consumes that butter or drinks that milk, the K2 enters the bloodstream and activates the proteins responsible for directing calcium into bone and keeping it out of soft tissue and arterial walls. For most of American agricultural history, this cycle was unbroken. Cows grazed open pasture. Butter was deep yellow, dense with fat-soluble nutrients. Families consumed vitamin K2 daily without ever knowing its name, because the name did not matter. The system delivered it automatically, invisibly through grass. Then the system was restructured. Beginning in the mid-20th century, American cattle were progressively moved off open pasture and into confined feedlot operations. Grain replaced grass. Corn and soy replaced clover and fescue. This transition was not driven by nutrition. It was driven by economics. Grain-fed cattle gain weight faster. They reach slaughter weight sooner. The production cycle compresses and profit per head increases. But grain-fed cattle produce almost no vitamin K2 in their fat or milk. The butter turns pale. The nutrient quietly vanishes from the food supply, and no government agency sounds an alarm because the USDA Food Composition Database does not distinguish between vitamin K1 and vitamin K2. To this day, the federal system responsible for tracking what Americans eat treats these two functionally different molecules as interchangeable. They are not. They never were. While this gap widened silently in the United States, something very different was unfolding in Japan. Japanese researchers had been investigating vitamin K2 since the 1960s, studying its effects on bone metabolism with a depth of focus that American institutions never matched. By 1995, a pharmaceutical company called Eisai had developed a high-dose K2 drug called Glacay. It contained menotretinoin, the MK4 form of K2, dosed at 45 milligrams per day. The Japanese government approved it as a prescription treatment for osteoporosis. Clinical trials demonstrated reduced fracture risk and measurably improved bone mineral density. It became a standard part of care for aging Japanese women. A molecule that photosynthesis produces in every green blade of grass on Earth was now dispensed through hospital pharmacies and billed through national insurance programs. Japan was not alone. Patented K2 formulations have appeared across parts of Europe and Southeast Asia. One company, Pharma, secured international patents on a branded form of K2 called ManaQ7. The molecule itself is as old as photosynthesis. The patent is modern, and the distance between the two represents one of the most quietly profitable gaps in global health commerce. In 2004, the Rotterdam study added a dimension that should have reshaped the American health conversation overnight. This large-scale Dutch research project followed over 4,000 subjects for more than a decade and found that high dietary intake of vitamin K2 was associated with a significant reduction in coronary heart disease and severe aortic calcification, not vitamin K1, specifically K2. The study indicated that this molecule did not merely support bones, it actively defended the cardiovascular system by preventing calcium from accumulating where it should never be. The findings were published in a respected peer-reviewed journal. In the United States, they were met with near-total institutional silence. Now, consider what was happening simultaneously in American medicine. Millions of adults, especially women over 50, were being advised to take calcium supplements for bone health. Calcium tablets became one of the most widely consumed supplements in the country. But without adequate K2, that supplemental calcium had no reliable guidance system inside the body. It entered the bloodstream with no specific destination. Some of it reached bone. Much of it did not. Arterial calcification quietly became one of the escalating health crises of the aging American population. And the molecule that could have directed that calcium properly, the one honored with the Nobel Prize, the one that Japanese hospitals now prescribe by name, remained almost entirely absent from standard American medical guidance. There is yet another layer that touches millions of households directly. Warfarin, sold under the brand name Coumadin, is one of the most commonly prescribed blood-thinning medications in America. It functions by blocking vitamin K activity in the body. Patients on warfarin are routinely instructed to limit their intake of vitamin K-rich foods, particularly green vegetables. They are told to keep their K consumption low and unchanging. What they are almost never told is that by suppressing vitamin K, the drug simultaneously disables the mechanism that protects their bones from weakening and their arteries from hardening with calcium. They are being medically managed into a deficiency of the very molecule the Nobel Committee recognized as essential to survival 80 years ago. Today, a growing number of Americans are beginning to discover K2 on their own, largely through independent research and word of mouth, rather than through their doctors. The supplement market for vitamin K2 has expanded significantly over the past decade, with bottles of MK7 capsules lining health store shelves at $15 to $30 a month. People are paying monthly for a molecule their grandparents received for free, from butter that came from cows that ate grass that grew in fields nobody had to plant, fertilize, or patent. And through all of this, the grass keeps growing. It grows along highway medians in Tennessee. It fills drainage ditches in Ohio. It covers pastures in Montana that no longer hold grazing cattle. Every single blade performing photosynthesis, every leaf producing vitamin K1, quietly waiting to enter a food chain that industrial agriculture disconnected and that no regulatory body has moved to repair. The molecule that won the Nobel Prize did not vanish from the natural world. It disappeared from the system that was supposed to deliver it to your table. The grass still makes it. Cows, when allowed to eat that grass, still convert it. Butter from those cows still carries it. The science has been published for decades. The Nobel record is public. The Japanese pharmaceutical filings are accessible to anyone willing to look. The Rotterdam data has been sitting in the open for 20 years. What changed was not the molecule. What changed was who profits from your access to it, and who profits from the distance between you and the grass that makes it. That grass is still outside your window. It is still performing the same quiet chemistry it has carried out for millions of years. The question that matters now is why the rest of the system decided to stop.